Okay, welcome back to the channel. If you didn't see the previous video, we went through 10 different NREMT practice problems. And this video is going to be going into more depth explaining those practice problems. So if you haven't seen that video, I recommend going back and checking that one out first, since this was going to build off of that one. So let's start with the first one. For this question, the answer was tension pneumothorax. Let's talk about why it's tension pneumothorax and not any of the other options. Let's start with myocardial infarction. So an MI, myocardial infarction, is going to be a heart attack, is the common term, but what that is tissue. I spelled that wrong. Death in the heart. So it's when the tissues of the heart are physically starting to die. So let's talk about like what that would look like, or what we would expect to see in a patient with that. We would see, uh, in most cases, we would see an elevated pulse, which in this problem we do have during early stages. We would have hypertension, um, which is the exact opposite of what this problem gave us. So that's kind of like a sign that it's not A. We would also, the patient would report feeling chest pain and radiating pain elsewhere. I put other pain. So very common in patients experiencing an MI. There is chest pain, there's pain potentially in the mouth and the teeth, and there's also pain radiating out to the left arm. So those are very common signs of MI. If you see any question on the NREMT that says pain radiating to the left arm, it's an MI. And if you see that on the field too, they're probably experiencing an MI. Very common signs of MI. So, and then we talked about hypertension in the early stages. In the late stages, that would change to hypotension. Hypo being low blood pressure, hyper being high blood pressure. So it would switch. Um, and then for respiratory rate, we would expect tachypnea. Um, and then we would also potentially see decreased O2 saturation. Could be could be normal, but it's also possible it's going to be decreased as well. It doesn't really say anything about respiratory rate or O2 in this question. It gives us the pulse and it gives us the blood pressure. Um, and the blood pressure for an early stage would be elevated. This one's low. Pulse matches up, but because we're not given any of the common signs of tissue death or pain or radiating pain, we can safely say that it's not going to be A. So, for tension pneumothorax, the reason why this is the answer, we'll get rid of all of this extra stuff. Oops. So, tension pneumothorax, which I'm going to label as TP, so I don't have to write it out every time. TP is when fluid builds up inside of the pleural space. And the pleural space is the space between the lung and the chest wall. And this fluid gets trapped there. And what it does is it puts pressure. So I'm going to put pressure with an up arrow. Puts pressure on the lungs, the heart, and certain vessels. Let me make that look nicer. certain vessels. So pressure goes on the lungs, the heart, and the vessels. And what this does is it lowers blood pressure because your heart cannot refill all the way. It can't pump as much blood out all the way with as much force. So there's less pressure, which we have. And to compensate, because your body likes to maintain homeostasis, it has all these different ways that it compensates. To compensate, it's going to increase the body's heart rate, the pulse. Um, so when something is out of the normal, out of homeostasis, typically the body has a method to counteract that. If your blood sugar is too high, your body releases insulin. If your blood sugar is too low, glucagon. If your heart rate uh, or if your blood pressure is too low, it's going to increase that pulse to help out. If you're not getting enough oxygen, your respiratory rate is going to increase. So different things that your body does to maintain homeostasis, your pulse is going to be one of them. When your blood pressure is low, which we see here, remember normal blood pressure is going to be 120 over 80. It will rarely ever be 120 over 80 in the field. That's just what your book tells you. 120 over 80 is normal. 90 over 60 is going to be low. And when your blood pressure is low, your body's going to jack that pulse up to compensate. So we see low blood pressure, we see an increased pulse, which makes sense. And then what really confirms this to be tension pneumothorax is going to be the lung sounds are diminished on the right side. This is almost always a telltale sign of some form of pneumothorax. The fact that it's trauma related. Remember, we got hit in the chest with a baseball, so it's going to be trauma. And the fact that we see, low blood pressure, high pulse, that kind of confirms that it's pneumothorax, and that really kind of confirms that it's tension pneumothorax. And tension pneumothorax is oftentimes caused by trauma. So we have the trauma, we have diminished lung sounds, and then we have the pulse and the blood pressure for it to be tension pneumothorax. All right, so moving on to pericardial tamponade. With pericardial tamponade, which again I'm going to abbreviate as, I'm going to do that as PT because I don't want to write that out. Pericardial tamponade and tension pneumothorax have a lot of the same signs and symptoms. Um, However, for PT, some of the distinguishing signs are JVD. JVD is very common in pericardial tamponade, and it's not common in tension pneumothorax. You can distinguish between the two like that. And then with tension pneumothorax, um, we're going to have those diminished lung sounds. So look for lung sounds that are abnormal in tension pneumothorax. For pericardial tamponade, typically lung sounds are normal. So that's how you would distinguish between the two. But other than those two big ones, a lot of similarities can be found between the two, and it can be hard to distinguish. So look for JVD and listen for abnormal lung sounds, and that's kind of how you would determine which one you're working with. Okay, and then moving on to rib fracture, which is our last one here. With rib fracture, you don't really get this diminished lung sounds here. That's going to be like a telltale sign of a pneumothorax of some sort, specifically tension pneumothorax. Uh, you could very well have a fractured rib in this case, very possible. But because we're getting these diminished lung sounds here, now we're thinking pneumothorax. So rib fracture could be the cause of the pneumothorax, but the most correct answer is going to be pneumothorax in this case. Okay, so moving on, you arrive to find a 50-year-old male who has collapsed suddenly. Bystanders are performing CPR, and AED is applied, and shows a rhythm is ventricular fibrillation. What's your next step? Correct answer for this one was C. And let's kind of get into why we would or wouldn't do these. So with this question, it's really just about order of operations. All of these are something that you would want to do. It's more about which would you do first? What's your next step? And the two best answers for this are going to be C and A. The reason why it's not A is because epinephrine is a less effective way of fixing ventricular fibrillation. VFib is a shockable rhythm, and it'll be important to learn your shockable rhythms. We won't go into that, but VFib is one of them. And we have the AED applied already. We have it connected, and it advises a shock. There's no reason not to shock. We're just going to shock the patient. There's no need to go looking for epi and drawing it up and administering it, and um, it's not as effective as simply shocking, especially when we have the pads already attached. So we're going to shock, and then before we shock again, if this shock doesn't bring them back, we're going to continue CPR for 2 minutes before we shock again. It gives the time for the AED to reanalyze and recharge, and then we can shock again after those 2 minutes of CPR. But first, we're going to shock, and then checking for a pulse before shocking. We don't need to do that because we already know what the rhythm is, and we already know that it's a shockable rhythm that needs a shock to be fixed. So there's really no reason not to just shock and get right into it. Number 3, 45-year-old female presents with severe allergic reaction after eating shellfish. She has hives, swelling, and difficulty breathing with low blood pressure. What is the best initial intervention? So 15 grams of oral glucose is wrong because this isn't a diabetic patient. She's not low in blood sugar. We don't have any signs, so it's not going to be glucose. Providing oxygen via nasal cannula. We probably would give oxygen at some point, and it would probably be at a higher flow rate than what a nasal cannula can support. Um, but we're not going to give oxygen right now because right now she can't breathe. She has difficulty breathing. Her airway's swollen. Um, we're not going to help. We're not going to add oxygen to that because she can't breathe right now. So we're going to open up her airway with the epinephrine, which is why B is correct. D, assist her with her prescribed antihistamine. So antihistamine um, is allergy medicine. Now, do these symptoms that she's experiencing sound like an allergic reaction? Well, kind of, yeah, they do. This sounds exactly like an allergic reaction. And we have allergy medicine with us. She has allergy medicine. We could give her allergy medicine. But this isn't going to do anything because this isn't just an allergic reaction. This is anaphylactic shock. It's advanced past just a simple allergic reaction. Now she's in anaphylactic shock. She needs something stronger than her prescribed antihistamine. She needs epinephrine, which, for those of you who don't know, epinephrine, which I'm just going to label as epi, is a vasoconstrictor, which means it closes up the blood vessels, and this redirects blood to the vital organs like your heart, your lungs. It takes it away from the extremities and relocates it to all the vital organs. It's a vasoconstrictor. It'll also open the airway, which in this scenario is perfect because we have difficulty breathing and our face and our lips, our airway is swelling up. So we absolutely need to open that airway, and guess what? Epi does that. So this is perfect. And the final thing it does is increases pulse. Forgive me for my bad handwriting. I know it's horrible, but try to work through it with me. Increases the pulse. So what happens when your pulse increases? Your heart pumps faster, right? It's pumping more blood out. It's pumping that blood out harder. What is that going to do to the blood pressure? It's going to raise the blood pressure. So this is exactly what we want. We have low blood pressure. Epinephrine raises blood pressure. We have difficulty breathing. Epinephrine opens those airways and makes breathing easier. A lot of being working in EMS and taking the NREMT is simply just solving the symptoms. When you go through your assessments and your sample and your ABCs, if you find something wrong, fix it and then move on to the next thing. If you go through your ABCs and you find something wrong with the airway, oh well, let's open that airway up. If you find something wrong with that breathing, oh well, let's give oxygen. If you find something wrong with that circulate, like you just go through each step. Go through your ABCs, your sample, your histories, and as soon as you find something that's wrong with the patient, you fix it. So when we go through, the we go through this patient's like symptoms right here. We have hives and swelling, difficulty breathing, and we have low blood pressure. These can all be solved with epi. Let's use epi, right? It's as simple as that. Just go through it, solve the issues, and you'll be successful. Okay. A 32-year-old woman is in her third trimester of pregnancy, complains of a sudden severe abdominal pain and vaginal bleeding. So we can underline this up here. And then she also denies trauma. So the correct answer for this was B. We can talk about why. So starting off with placenta previa. Placenta previa is when the placenta covers the cervix, and this is usually painless. There might be some bleeding, but it's not going to be painful bleeding, and we can see up at the top that she has severe abdominal pain. So likely not that. And this is also diagnosed much earlier than uh, than any other, well, than the actual answer, which is uterine rupture. We wouldn't be in the third trimester when we discover this. This would be found out much earlier. Ectopic pregnancy is when the fertilized egg implants outside of the uterus, and this usually happens in the fallopian tube. And this is another one that is usually noticeable in early pregnancy. If the mom has been going to her scheduled checkups to check on the progress of the child, you're probably going to notice this really early on. It's not going to be something that you find in the third trimester, so we can kind of eliminate that too. Preeclampsia is when there's high blood pressure and like high protein in the urine, and this is also accompanied by swelling. But again, doesn't usually cause severe abdominal pain, and it's not really going to cause vaginal bleeding either. It can, however, cause headaches and like visual disturbances, such as like photosensitivity, and then we can also see some systemic symptoms with that. But there's not really going to be any bleeding, and there's not going to really be any abdominal pain, so we can eliminate that. That leaves us with uterine rupture, which is exactly defined by the symptoms that we have. We get vaginal bleeding, we get severe trauma, and it can oftentimes be, or sorry, severe abdominal pain, and this can also come along without any trauma. It just ruptures. So that's why B is going to be our best answer, especially because this can happen late in the pregnancy as well. It's very common to happen late in the pregnancy, uh, especially if labor is about to start. It's going to be like a late pregnancy to labor type condition. Um, so yeah, that's why B is going to be our best answer. Pediatrics. A 3-year-old is unresponsive and cyanotic after choking on a small toy. You cannot hear any air movement and see no chest rise. What should be your first intervention? So, starting off, chest compressions. This patient is unresponsive, but we're going to assume that this patient has a pulse, um, just for the sake. Because if the patient didn't have a pulse, yeah, okay, we'd probably start chest compressions. It doesn't say that though, so we're not going to go start making up symptoms. Um, if the question doesn't say that the patient has no pulse, we're not going to say that the patient has no pulse. Performing a blind finger sweep. We never do this, ever. Nowhere is it in the protocol to perform a blind finger sweep. Now, some protocols might say that it's okay to sweep if you see the object visibly in the throat. Never going to be blind though, so we can get rid of C right off the bat. And then attempting ventilations. Why, right? Like the airway is blocked. All of that air is not even going to make it to where it needs to go. If anything, you might just push that small toy further into the child's airway. Given the age of the child, delivering abdominal thrusts followed by back blows would be the most proper course of action here. And a lot of this is going to be using your detective skills, right? So when you get on scene, you can potentially see that the patient is choking or audibly hear the patient choking. Just ask somebody on scene, hey, is this patient choking? Or look around. Maybe you see some toys scattered on the ground. Maybe this patient's choking on like a chicken bone, and you see that there's chicken on the dinner table. Um, or you can just ask anybody who's on scene, hey, is this child choking? And boom, there you have your answer. This child's choking, yes. So now we can get right into problem solving And for this patient, it's going to be abdominal thrust. So really, as simple as that, use your detective skills, look around, pick up clues. A 70-year-old male with a history of COPD is experiencing difficulty breathing. He is sitting in the tripod position, which is going to be bent over, hands on your knees, for those of you who don't know, using accessory muscles to breathe. And those are going to be that's going to be breathing with your diaphragm. And if you don't know what that looks like, it's like the bottom part of your chest wall is going to be expanding when it should be kind of like the upper part that expands out while you breathe. That's what accessory muscles is. And his oxygen saturation is 85%. What is the most appropriate treatment? So we're going to skip down to C actually and get rid of C right off the bat. Uh, Normal oxygen is typically seen to be 95 to 100%. If you've got anything lower, like let's say 90 to 94%, then we would use a nasal cannula at 2 liters a minute. That's kind of like a lower amount. Because we're all the way down to 85%, we're going to want much higher flow. We're going to want 10 to 15, 15 probably the safer option given that it's so low. Um, so we're not gonna do 2 liters a minute. That's way too low. We can get rid of C. Have this patient breathe into a paper bag. Um, we don't carry paper bags on our ambulance for starters, and I mean I don't really know why that was ever a thing that was recommended. I know it's very popular. It's very common knowledge that you breathe into a paper bag when you're like nervous. I don't know the reasoning behind it. I just know that we don't carry paper bags in our truck for breathing, so we're not going to do that. And assist with ventilations is also wrong. So let's talk about why. Um, we're kind of like looking at them. We want to find the main problem here. What's the biggest issue that this patient is experiencing? And right now, the most daunting sign to us is going to be that 85% oxygen. We should start trying to fix that first. Um, Keep in mind, we don't want to over-oxygenate with COPD. We'll talk about that in a second. But right now, our biggest concern is going to be that oxygen. So we don't want to use BVM because it's typically going to be for patients who can't control their own airway. And this patient, we can see that he's controlling his airway. He's not doing it well. He's not breathing properly, like it says accessory muscles, which is not proper breathing, but he's still breathing, so we don't really need to assist in ventilations there. So we would want to apply 15 liters of oxygen a minute via non-rebreather for this patient. And the reason why we want to be careful about over-oxygenating this patient is because he has so the reason why we don't want to over-oxygenate these patients is because COPD patients rely on hypoxic drive in order to know when to breathe in. What hypoxic drive is when the body detects that there is low oxygen levels in the body, which is hypoxia. It stimulates breathing. We breathe in when we have low oxygen. This isn't normal for normal people. I don't want to say normal people. COPD patients are people too. But patients without COPD, they operate on a different kind of way. Instead, the body knows when to breathe when CO2 levels get too high. Now, COPD is essentially chronic elevation of CO2. So instead of relying on their CO2 levels to know when to breathe, they use hypoxic drive. And that's rather than CO2 being too high, I need to breathe in, that's going to be oxygen is too low, I need to breathe in. And oxygenating these patients could throw off that hypoxic drive, and now they could potentially lose the ability to breathe for themselves, which is why we want to be careful with that. And please forgive me if I cough or clear my throat. I'm getting over a cold right now, but I wanted to get this out, and it keeps me sane recording videos. Anyways, a 30-year-old woman has been involved in a motor vehicle accident and presents with rapid, weak pulse and cool, clammy skin. She has a penetrating wound to the abdomen, and her blood pressure is 80 over 40, so that's low blood pressure. Um, what type of shock is she most likely experiencing? So let's go through each of the shocks. We'll start with cardiogenic, and I'll put that as, we'll say C, or we'll do CS for cardiogenic, SS for septic. Over here we'll do HS, hypovolemic, and then NS for neurogenic. So, starting off with cardiogenic shock, this is going to be shock as a result of something wrong with the heart. So, we'll say heart issue. It's an issue with the heart. And this can be caused by a lot of things, such as an MI, which is myocardial infarction, otherwise known as a heart attack. It can also just be caused by simple dysrhythmias, heart failure, a whole bunch of different things. And this is when um, your heart fails to pump out enough blood, which leads to shock. And if you don't know, and you should know shock and the signs and symptoms of shock. But if you don't know, shock is equal to hypoperfusion. Hypoperfusion, which is lowered perfusion. Perfusion referring to the oxygen reaching the blood and the blood reaching the body and the body receiving that oxygen. Hypoperfusion, that's lower than what it should be. Signs and symptoms for shock are what we're given in this question. Essentially, we're given cool, clammy skin. Low blood pressure is kind of like that starts to get into like the later stages, and you're also going to see hypoxia, which I don't think it says in this question. Right, no, it doesn't give us an O2 reading, but hypoxia is going to be one of them. To treat shock, very little we can do pre-hospital. Try to keep them warm. Put them on high flow oxygen, 15 liters a minute was good. Elevate their feet, kind of get those fluids flowing back to the center is kind of like the thought process by elevation. And then if you are an AEMT or a medic, or you're becoming one of those right now, you can start them on an IV, which will boost that blood pressure back up. So, some medics will do a double IV, one in each arm. Essentially, setting them up on a normal saline IV is going to raise their blood pressure, add more volume into those veins, um, which can bring them out or temporarily prevent shock from preventing further or progressing further. So those are options if you're higher level. If you're just a basic EMT, keep them warm, put them on oxygen, elevate those feet. Shock treatment. Drive fast is also important. You're going to want to transport. Anyways, moving on. So we got septic shock. So septic shock is going to be shock from a result of an infection. Put that here. So it's going to be from an infection, and then a systemic infection, which is going to be an infection that affects your entire body essentially, is going to be sepsis. That's what sepsis is, and this is going to cause inflammation, which I will put here. You see a fever. You're going to see, a lot of cold signs, a lot of flu signs, stuff like that. Irritation. This can be caused by fungal matters. It can be bacterial. Wow, my handwriting looks absolutely horrible. And it can also be um, viral. So, infections that go on for too long that your body can't fight can lead to septic shock. So now we have hypovolemic shock, which is the correct answer for this question. Hypovolemic shock is simply shock as a result of low volume in the vessels. Loss of blood can cause this. Significant loss of fluid in general can cause this because there's other fluids kind of like in the vein that aren't specifically blood, but losing blood is the biggest one. And if you look at this question, that's exactly what we're given. We're given a penetrating wound to the abdomen. It's reasonable to assume that she's bleeding, especially with this low blood pressure. She's probably bleeding. It's reasonable to assume that. So we can put that here. Loss of blood slash volume. Hypo, low, volemic, volume, low volume. Shock as a result of low volume. Simple as that. Know your vocabulary. And then neurogenic shock is going to be shock that it's very similar to hypovolemic shock actually. When your nervous system gets affected or damaged, sometimes your body loses the ability to keep those vessels firm. So it's going to be related to the nervous system. And then the vessels lose their firmness. And when that happens, I mean, your vessels lose their shape, their firmness, they start to open up a bit. The amount of pressure is going to go down. That amount of volume is essentially going to go down too, right? Because you're putting the same amount of fluid in a much larger space. So you're going to have less pressure and you're going to have overall less volume as well. Um, so similar to hypovolemic shock, however, the difference is in this question, there's no sign of nervous system damage. There is sign of bleeding and blood loss. So that blood loss would lead to hypovolemic shock. If there was signs of nervous system damage, we would start to suspect neurogenic shock. But because we have this penetrating wound, we're going to expect hypovolemic shock. A 40-year-old construction worker falls from a ladder and is found lying on the ground unconscious. He has snoring respirations, and you notice an obvious deformity in his right leg. What is your first priority? So, right off the bat, we're given two kind of like red flags. We're given this deformity in his leg, which certainly is an issue, but what's more concerning is going to be that snoring respiration. That means he's got something wrong with his respiratory system. Um, so, going down list by list, splint the leg, which is more life-threatening, not being able to breathe properly or having a broken leg. It's going to be not being able to breathe properly. So, splinting that leg, not going to be our first priority. Assessing for signs of spinal injury. This is going to be something that you should be able to do kind of as you walk up to the patient. Not really assessing, but suspecting. Whenever you have a fall, especially after they reach a certain age, I believe it's 65, any sort of fall at 65, you're going to suspect spinal injury and you're going to put on a C-collar. But anytime you have someone who's fallen or any kind of trauma at all, you always want to suspect spinal injury. So we're not going to really assess right away because we're just going to assume that he has spinal injury and we're going to start treating that. So we're not going to assess for signs of spinal injury first. First thing, and we're not going to check for blood pressure either because this patient is currently having issues breathing. If his blood pressure is low or high or abnormal in any way, there's nothing we can really do right away. We want to treat what is most important and what we can treat the fastest. And that's going to be opening the airway because we know his airway is obstructed. He's got snoring respirations. That's an upper airway obstruction. Typically speaking, that's going to be when your tongue is covering the airway. You get that kind of respiration, snoring sound. We need to fix that. Now, there are two ways to fix it. There's the good old-fashioned head tilt, chin lift, and then there's the one that is shown in answer B, jaw thrust. So, why is it jaw thrust and not head tilt chin lift? Well, if we're suspecting spinal injury, which we are because this patient is a fall patient, he fell from a ladder, we're automatically going to expect a spinal cord injury. We don't want to change the natural alignment of the spine, and we don't want to move it any more than it has to be. So we're not, and for a head tilt chin lift, you have to, manipulate the spine. We don't want to do that. So without moving the patient's head or spine, we're going to do a jaw thrust. And we do a jaw thrust anytime we need to open the airway and we suspect spinal injury. So a jaw thrust is just going to be two thumbs kind of like on the back of the jaw, right on your jawline where it starts going up towards your ear, and you're just going to push that jaw forwards and make you look like a Neanderthal. Essentially is what you're going for. Try to make your patient look like he's got a big old underbite, and you'll be doing a jaw thrust. And that'll open up the airway without manipulating the spine, which is, in this case, exactly what we want. 65-year-old male complains of chest pain that radiates to his jaw and left arm. He is pale and diaphoretic. His pulse is 110. His blood pressure is 140/90. What is most likely the cause of his symptoms? So I only underlined the part that says pain that radiates to his jaw and left arm because these are telltale signs of a heart attack. Whenever you see left arm pain, radiating left arm pain in the field or on an exam, think heart attack. That's probably where they're going. Um, but we'll go through each of the other questions as well. So, for aortic aneurysm starting out, um, we do expect to see some of the things shown here, like the high pulse, the chest pain, and the elevated blood pressure. What really confirms that it's not an aortic aneurysm is going to be the jaw and arm pain. With an aortic aneurysm, chest pain is common. We would see that. However, we're not going to really see that left arm pain. That's kind of like, that's very exclusive to myocardial infarction, so it's not going to be aortic. Pulmonary embolism is going to be kind of the same thing. That's when you get like Well, I didn't say what an aortic aneurysm is. An aortic aneurysm is when you get like a little bulge in the aorta in the vessels, kind of like a bulge. That's what an aortic aneurysm is. Pulmonary embolism is going to be like an air bubble inside the lungs, inside the vessels of the lungs. That's what a pulmonary embolism is. And again, this can also present like a heart attack. A lot of the same symptoms, a lot of the same signs. However, again, not going to have that left arm pain. Pericarditis, again, all of these kind of have similar symptoms and signs. Pericarditis, however, has its own kind of defining symptom. So, with pericarditis, it is very likely that you can have a small fever, but still a slight high fever. So, and this is also very common if the pericarditis is led on by an infection of some sorts. Viral infections, for example, can lead to pericarditis. So, if you have a patient presenting with all of these symptoms, don't be afraid to take that temperature and see what you're working with. If their temperature is normal, you can start thinking myocardial infarction, heart attack. You should already be thinking that because of the left arm pain and the jaw pain, but if you haven't assessed that yet, go into that temperature, take that temperature. If he's got an elevated temperature, even if it's just a little bit, now you can start thinking pericarditis. You still want to confirm that there's no left arm pain or jaw pain, since those are very common in MIs, but that temperature can also eliminate an answer or two. Okay, last question. A 30-year-old diabetic male is found unresponsive with shallow respirations and a fruity odor on his breath. His skin is warm and dry. What is the most likely cause of his condition? So, is it hypoglycemia, hyperglycemia, stroke, alcohol intoxication? This one's going to be B, hyperglycemia, which is high blood sugar. So let's actually start with D and explain why D isn't going to be the most likely answer, which, by the way, on the NREMT is going to be a lot of right answers shown. Pick the one that's most right. NREMT can be tricky like that. So the reason why D is not the most right is because while being drunk can cause respirations to be depressed, and you might get an odor on the mouth, might not be fruity. Um, we know this patient's diabetic because it tells us that. So we should already be thinking of something related to diabetes, either hypo or hyperglycemia. Um, Sometimes they would give you a question on there that includes information that's just meant to throw you off. This isn't one of those cases. So, again, on the scene, on the job, use your detective skills, right? Like, ask questions. If there's anybody around, ask for questions. Look for medical alert tags. Look for maybe this patient's carrying around, insulin shots. Look for stuff like that to give you clues on if he's diabetic or not, or what his condition could be. And right off the bat, we can eliminate alcohol intoxication because we know he's diabetic, so it's probably going to be something related to his diabetes. Moving up to stroke, this question didn't give us any really major stroke signs. It didn't talk about gait, it didn't talk about facial droop or anything like that, slurred speech. All it says is he's unresponsive with shallow respirations and he's got that fruity odor on his breath, which should be setting off like alarm bells in our head. So that leaves us with hypo and hyperglycemia, which is great because we've already narrowed it down to those two and we figured it's going to be related to diabetes. So let's look at what I have underlined, which is fruity odor on his breath. This is a telltale sign of diabetic ketoacidosis, which is a condition typically found in patients with type 1 diabetes, could be type 2. Usually it's going to be in type 1 diabetes, and it's when your insulin is very low, your blood sugar is going to be really high because there's not enough insulin to let that glucose into the cells, so it remains in the bloodstream. You're going to have high blood sugar, and something else that happens with diabetic ketoacidosis, which is really fun to say, by the way, the fat cells in your body start getting broken down, and this releases ketones, which are acidic byproducts of fat being broken down in the body. And these ketones, combined with the elevated high sugar in the blood, can lead to a fruity odor, a sweet-smelling odor coming out of the patient from their mouth. So this fruity odor that it gives us as a sign is very, very like this should be setting off like warning bells in your head, right? Like this is a telltale sign of it's diabetic ketoacidosis. We call it DKA for shortened easier to say purposes. So I'll throw that up there. DKA, diabetic ketoacidosis. Fruity odor on the breath is a very telltale sign. It should be freaking you out when you see that. So look for that. And then hypoglycemia, which is low blood sugar. I mean, okay, think about it, right? When you if you were to tear into an orange, a sugary orange, right? It's gonna smell a lot, right? It's got high sugar, it's got high citrus content. It's gonna smell. It's something that's very sweet. So it makes sense that the more sugar you have, the sweeter the smell, the fruitier the smell, and you're not gonna get that with hypoglycemia. So we can throw that out of there. So yeah, sometimes you get lucky on the NREMT where it gives you a question with a major telltale sign that eliminates everything else. You just got to know those signs, and this was one of those questions. So we can kind of just eliminate everything else by default because we have this one symptom. So that'll be it for this video. Check out the other one if you haven't already. Thank you for watching, and I'll see you on the next.